Tēnā koutou katoa. Thank you, Mark. Really, really lovely to be with you again this morning and to be able to give you this update on our numbers of HIV and AIDS cases in New Zealand. So I just want to start with this and make sure that I can get this. Normally I start with our numbers. I just want to bring this into context by, again, just reminding you of our lovely action plan that was produced last year and published last year in 23. And for you to sort of be able to keep this in mind when we're looking at the numbers. So in Aotearoa New Zealand, where HIV transmission is eliminated and all people living with HIV have healthy lives free from stigma and discrimination. And underneath that, there's a lot of other things in that document, as many of you well know, but these 5 main goals. And I think probably from an epidemiological point of view, a lot of our focus is on goal number 1, but also on goal number 5. And so some of the slides that I'll show you today, just keep those in mind, and I will keep coming back to this National Action Plan and these goals and this overall vision as we go forward. So this is the figure that we always have in our AIDS New Zealand newsletter from our surveillance right back from 1985. But of course we're sort of looking more current, aren't we? And you know, you can see there the peak in 2016, very sharp drop-off since then, and you've seen this slide many times before. 2021 and 22 were very low numbers. Last year, they went back up again. And so, you know, we're keeping an eye on that for this year. We would still say that it's a trend downwards, even though it's up from the 2 previous years, which are most likely to have been influenced by COVID and the social restrictions around COVID. But if you look and take a trend from, say, 2016, that peak, it's still a trend downwards. But we're looking at what's going to happen this year, so, and whether there is a trend that continues or what happens. Last year, I guess just to show you the numbers, you know, we're looking at very small numbers here in New Zealand. We're very, very fortunate in that sense. So a total of 97, mostly men, 14 women and 1 transgender person. So now just with us in epidemiology, we sort of like to break numbers down from the bigger picture down into different groups and different places of acquisition. So this is just looking at men who have sex with men, just diagnosed in New Zealand, and this is by place of acquisition, with the black line at the top being acquired in New Zealand. And so you can see that really sharp decline since 2016 and locally acquired infections. And as I mentioned, with the overall picture up again last year, but let's wait and see. And just thinking in the context, and I will come back to this again later, that with the target that we have is of meeting a 90% reduction in locally acquired infections compared with a 2010 baseline, which is this green line that I've put in there just to help you see what we're dealing with. When we break this down even further and look at it, this is MSM with locally acquired HIV, and just looking from 2010, which is our baseline. And so we can see there that blue line at the top, which is European men. So the main reduction we've seen in European men. Amongst Māori, Pacific, Asian, African, you know, these are very, very small numbers. You can see since 2010, tracking along 10, 12, 14, very, very low numbers. So that's really great, but they're not really changing. They're just staying along at that same low number. We're not really making much of an indentation there. If we look at place of residence at the time of diagnosis, The blue line at the top is the northern region, which is Auckland and north, mostly Auckland. And so the main reduction is in people living in this region. Again, that increase that we saw in 23 was mostly in the northern region. Amongst the other regions, Te Manawataki, Central, Te Waipunamu, so Central, Midlands, Southern, again, just trekking along at fairly small numbers. So when we think about that goal number 5 that I mentioned at the beginning of increased equity in relation to all the HIV goals, this is what we're looking at. You know, are we reaching all people of all ethnicities and in all the regions? The other thing we always like to look at is the timing of acquiring HIV. So to do that, we look at the CD4 count at the time of diagnosis. And again, we're just looking at people with locally acquired HIV. And it's a wee bit hard to see with this, but the green line at the top is a CD4 count over 500. And so mostly it's a decline in these newly acquired cases that we've been seeing. I think just to make a note though, when thinking about late diagnosis, and because we have such small numbers, I've put this in brackets of five yearly brackets. So 2010-14, there were 32% who would be considered a late diagnosis, CD4 count of less than 350. Similar in the 2015-19 bracket, slightly higher late diagnosis in the 2020 to 23. But this gets a wee bit complicated because as the numbers get smaller, the proportion of people who will be tested and being diagnosed late, the proportion will be going up. So numbers going down, but proportionally of those who are being diagnosed in 1 year, the proportion of late diagnosis will go up, probably as we get closer towards elimination. When we're looking at age at time of diagnosis of MSM, you know, really they are all ages. In 23, the mean age was 38 years, an age range from 20 to 75 years. I think it's a slightly complicated picture. If we look at 23, there was that increase, the blue bar in 23 in the younger age men, but I think it's really important just to remember that it is that wide age range of MSM who are acquiring HIV. So just moving now to look at men and women with heterosexually acquired HIV, and this is also breaking it down by reported place of acquisition, and I guess not surprisingly, there is that pretty even numbers of acquired in New Zealand and overseas, particularly in these last 10 or so years since, say, 2014. Earlier on, there was a lot more overseas acquired heterosexual cases. Now it's similar, New Zealand and overseas. Again, just to note the very small numbers, you know, I'll put this up. From 2010 to 23, we're looking at an average of around 14 a year. Again, you know, it's kind of to be celebrated, 14 a year, but actually that's still 14 a year. And not much change over that time. Like, we're just, again, not making much of an indentation into that. It's just sort of trekking along at that small, low number, but still 14 a year. Heterosexual men and women, this is the slide showing that breakdown. I think one thing to note, so the mean age in 23 was 32 years, but tends to be an older mean age of heterosexual men compared to heterosexual women at the time of diagnosis. So heterosexual men being a bit older than women. The other difference between heterosexual men and women is amongst the men, it's a higher proportion who are European men, whereas amongst the heterosexual women, it's around half who are heterosexual. It's on the far right here, a higher proportion, so 21% who are Māori women, and the other ethnic groups as well of Asian and Pacific and African. So slightly different breakdown in the ethnic groups. Just moving on to the number of people diagnosed who reported injecting drug use, so people who inject drugs, and the target for this is to sustain the low incidence of HIV among people who inject drugs. And again, just really alert you to the y-axis, which the top number is 9. So very tiny numbers each year, and the blue segment is reported to have acquired HIV in New Zealand. So very tiny numbers. This is really good. We need to keep this going. Perinatal transmission, this is just up to 22. And again, the target for this is to maintain 0 cases of perinatal transmission. And so we haven't had any cases of locally acquired New Zealand-born perinatal cases since 2007. So coming back to our target, so comparing 90% reduction from 2010 baseline, this is a little bit of sort of fairly simple modelling that we've done just to look at when are we likely to get to this 90% reduction. And so the bottom line, so we need to get to 9 cases a year. You know, this is a really, really difficult target to reach, I have to say, you know, to get to 9. So our estimations, and this is based on the same rate of decline from 2016 to 22. We do need to update this now to 23. And assuming no changes in treatment or diagnosis or preventive actions, the soonest we think we can reach it is 2032. That's probably going to be pushed out now once we recalibrate this to the 23 numbers. So it's a very ambitious target. I think it's great to have the target, but you know, it's going to be very ambitious. Just wanted to also look how we're doing compared to other countries, and I'm aware we've got some Australian colleagues here. So, and this is just data up to 22, and so they've also seen a decline in their cases, and I think their top line is men who have sex with men. I've just been at a conference in Australia, and I had noted there that, and it's not published on their website, but 23, their numbers were also increased again. And interestingly, in the United Kingdom, and this is just data that came out at the beginning of October, a really, really sharp increase in the number of heterosexual, so sex between men and women, the orange line at the top, and then this news story, rise in HIV diagnosis, the steepest amongst heterosexual men and women. I tried to have a look to see if they were giving any reasons for that. Couldn't see anything that was being presented, but found that quite interesting, whether we were just talking before we came in here with Graham, and whether it's a bit of late diagnoses there as well, but I'd have to have a look in a bit more detail. But just to give you some idea of what's happening, I think every country, we've got this goal of elimination. It's not that easy to get to. So the other thing I just want to alert you to, so up until now I've been talking about HIV diagnoses in New Zealand. Last year we saw a very high increase in the number of people first diagnosed overseas, but coming to New Zealand, whether they be New Zealanders coming back or people from overseas coming here, having a first viral load test for monitoring, and so that's how we capture them into our data set. So very steep increase last year. This was people of all different ethnicities, but I think if you look at the 23, which is the blue line, it was mostly people, Asian, African, and MELA, Middle Eastern, Latin American. Also, just to try and put this into some context, so New Zealand saw the greatest increase in annual migration last year overall. And so people living with HIV were 1 per 1,000. So even though, yes, we've seen this increase in numbers, proportionately as of all the people coming into New Zealand last year, it was very tiny. And I also put this up, I'm not sure how easy it is to see where people are mostly coming from. So in 2023, it was mostly from India, Philippines. This is from Stats New Zealand website. So India, Philippines, China, and also Fiji. And so some of you will be aware there's a lot of HIV happening in Fiji at the moment, so this is something we're also looking at in our data. Just aware of the time. So just moving on to another goal that we have in the action plan of decreased mortality, and of course we have these targets of 95, 95, 95. We have looked at this over the last 3 years of who's on ART and with a suppressed viral load. So we've looked at it 3 times, each time using data just from 2006. So the dark red line is 2006 to 2020, the middle bar is 2006 to 21, and then the most recent is up to the end of 23. So doing pretty good with the proportion that we estimate to be on ART, suppressed viral load slightly down in the last 2 rounds of analysis, possibly related to COVID, not sure. But we will do another round again with data up to the end of 23, and we'll be doing that over the next couple of months. Just having a look at AIDS diagnoses, sometimes this gets a bit forgotten, so our target is for no AIDS-related deaths. So the black line at the bottom is deaths. Sometimes these numbers can be a wee bit delayed by the time we get them, but we are still very, very small numbers, but we shouldn't be having any AIDS-related deaths, and so that is the target that we need to keep an eye on. We shouldn't be seeing any AIDS cases or AIDS-related deaths. So just to summarise, so the number of MSM with locally acquired infections has declined, and I've got a few buts that you can see in here, but we're just watching and waiting to see what happens this year. The main decline is in European MSM, but minimal change in the other ethnic groups. Low numbers, but minimal change. Low number of heterosexually acquired HIV, but I believe it still needs to be lower. We need to make some indentation there. Increase in number of overseas diagnosed cases. There's no but here. That's something to be celebrated in some ways because of all the work that the Burnett Foundation have done in terms of changing the immigration laws. And so there is a real need to make sure that there is enough care and treatment and support for those people coming in from overseas and that they are welcomed into New Zealand. We're doing okay with the other targets, but ... And I think we just need to maintain vigilance. I think, we all know we're in the health sector here, of all the cuts, everything that's going on in the health sector. There's no given that we just need to maintain vigilance and keep the foot on the pedal, I think, so to speak. And UNAs have this of leaving no one behind, and that's really important to make sure that everything we do is equitable and delivered to the groups of people who need it. So I just want to acknowledge, thanks again Mark, Body Positive sponsors, all of you wonderful people who keep providing the data to us, and the laboratory staff. We absolutely would not be able to do that without you. And thanks also to my colleagues, Jerem and Ashley, and funding. And I'm just going to put this last slide up. Anyone who's interested, Jerem, my colleague who's sitting in the second row there, is also doing a qualitative study this year of wanting to interview people who are struggling at being on ART or keeping their viral loads suppressed. So if anyone's interested in that, either talk to Jerem in the break or his contact details are there. Kia ora, thank you very much for your time.
We do probably have time for like one question, if somebody had a burning interest. Yeah.
Hi, thank you for all the data. I'm Clara Dawkins and I work with the Community Drug and Alcohol Service. And I also was a GP in South Auckland before. I don't know if you guys could hear me. Is it on? Yeah. Do you think the low numbers are maybe related to the fact that many people are not being tested? As a GP, I'm seeing the lack of access to primary care, and the majority of men don't get to come to our services. So I do wonder whether the low numbers might be a reflection of that. How can we improve it?
So low numbers related to access to testing. Our colleagues at Burnett Foundation, I think there's been a lot of work going on in the last couple of years to improve that access to testing, and particularly developing point-of-care tests and making test kits available, posting up test kits and having testing available. So I'm not sure. That could be the case in sort of remote areas of New Zealand, but I think the access to testing has probably gone up. We don't have data on testing. Don't know. Anyone else want to add?
I just want to make a comment that our population, the ones who use drugs and alcohol, we need a lot more support for testing. And Body Positive is doing with the sexual health, is doing a pilot to try to have a collocation of testing. So I appreciate the support from sexual health. Because my population does not engage with general practitioners. And not all of them who use methamphetamine will go into Burnett Foundation or into Body Positive.
And also I think, like the late diagnoses, when you think about testing and perhaps, people presenting to GPs, to clinicians, and maybe not being tested in a timely way as well. Not last year, but the year before, a lot of our notifications in the MSM were an older aged MSM, and it was kind of like, well, what's going on there? And there were a lot of late diagnoses as well, and kind of how had they missed the access to testing thing, and how had they not been picked up earlier? So we always have lots of questions with this data as well. But some of those harder to reach people, and particularly thinking not necessarily testing, but the study that Jerem is doing this year, being able to stay on ART, and some of the difficulties with that will perhaps be some people who are not engaged in the services very well, which will be a similar perhaps to testing.
Thank you.